This is a video in clinical medicine from the New England Journal of Medicine.
Endotracheal tube exchange is an important part of airway management in patients in intensive care units, operating theaters, and emergency departments. In most cases, the procedure involves replacement of either an oral tube or a nasal tube with a new oral tube. The choice of equipment and technique depends primarily on the experience and preference of the physician. In this video, we demonstrate video-assisted endotracheal tube exchange with the use of an airway exchange catheter, a technique that is particularly useful in patients with a difficult airway. Endotracheal tube exchange is indicated when the tube that is currently in place has a cuff leak, needs to be replaced by a tube of different size, needs to be switched from single lumen to double lumen tube and vice versa, or when a nasal tube needs to be replaced with an oral tube. Endotracheal tube exchange should be avoided in patients with an extremely difficult airway. In these patients, tracheostomy should be considered. In addition, the procedure should not be performed unless the necessary equipment and personnel who have experience in performing the procedure are available. To perform the procedure, you will need non-sterile gloves, a 10 milliliter syringe, water-soluble lubricant, an anti-fogging agent, tape to secure the new endotracheal tube in place, and an adapter for the airway exchange catheter. You will also need a video laryngoscope that accommodates blades of different sizes. If you are replacing an oral tube, you will need a new 7 or 8 millimeter oral endotracheal tube and an airway exchange catheter that is more than 80 centimeters in length and has an external diameter of 19 French, which will allow it to fit inside an oral tube with an internal diameter of at least 7 millimeters. If you are replacing a nasal tube, you will need a 6.5 or 7 millimeter oral endotracheal tube, a stylet that will fit inside the oral tube, a flexible bronchoscope with an external diameter of 4 or 5 millimeters, a slit or pharyngeal airway to accommodate the fibroscope during oral intubation, and an airway exchange catheter that is more than 80 centimeters in length and has an external diameter of 14 French, which will allow it to fit inside a nasal tube with an internal diameter of at least 6 millimeters. To prepare the patient for the procedure, administer 100% oxygen until the end tidal oxygen level is 90% or higher. Induce complete muscle relaxation with the use of medication prescribed in accordance with guidelines at your institution. Mark the depth of the airway exchange catheter by measuring the length of the tube and the adapter. The tip should not extend beyond the end of the tube. Lubricate the airway exchange catheter. For the replacement of a nasal tube, insert the stylet into the new oral tube. Check the video laryngoscope and the flexible bronchoscope to make sure they are working properly. Also, make sure that you have an emergency resuscitation cart at hand in case the patient has a difficult airway. At least 2 persons who have experience with this technique should be present at the bedside. To replace an oral tube with a new oral tube, begin by inserting the video laryngoscope alongside the currently placed tube until it reaches a point that will provide visualization of the tube exchange procedure in the glottic region. Next, advance the lubricated airway exchange catheter through the previously attached adapter until it reaches the determined mark. You should not encounter any resistance. It is important to avoid delivering oxygen through the airway exchange catheter because that can lead to barotrauma if the tip of the catheter becomes accidentally placed in a bronchus and causes occlusion. Then, deflate the cuff of the oral tube that is currently in place and remove the tube. Make sure that the airway exchange catheter is not dislodged from the glottis by holding it in place. Thread the new oral tube over the airway exchange catheter. Consider rotating the tube as you insert it. Inflate the cuff and then remove the airway exchange catheter. Make sure that a carbon dioxide tracing can be seen on the anesthesia monitor. To replace a nasal tube with an oral tube, begin by inserting the video laryngoscope. If you can visualize the glottis, advance the lubricated airway exchange catheter through the previously attached adapter until the catheter reaches the determined mark. Under direct visualization, withdraw the nasal tube to the level of the hypopharynx. Advance the new oral tube with the attached stylet alongside the airway exchange catheter until the cuff cannot be seen. Remove the stylet. Withdraw the airway exchange catheter to the level of the hypopharynx. Inflate the cuff of the oral tube, then remove the laryngoscope. Check the anesthesia monitor for a carbon dioxide tracing, then completely remove the airway exchange catheter and the nasal tube. If you cannot visualize the glottis with the video laryngoscope, remove the laryngoscope and place a slit oropharyngeal airway in a midline position. Ask an assistant to perform a chin lift and jaw thrust maneuver. Insert the flexible bronchoscope through the oropharyngeal airway, positioning the tip in the supraglottic region in order to visualize the airway exchange catheter and removal of the nasal tube as you proceed. Using the adapter, advance the lubricated airway exchange catheter through the nasal tube until it reaches the previously determined mark. There should not be any resistance. Deflate the cuff of the nasal tube and, under direct visualization, withdraw the tube to the level of the hypopharynx. Insert the flexible bronchoscope alongside the airway exchange catheter toward the carina. Then, advance the new oral tube over the bronchoscope. Watch for the tube to appear on the screen, then advance the tube until the tip is positioned 3 to 4 centimeters above the carina. Withdraw the airway exchange catheter to the level of the hypopharynx. Inflate the cuff of the oral tube, then remove the bronchoscope. Make sure that a carbon dioxide tracing can be seen on the anesthesia monitor, then completely remove the airway exchange catheter and the nasal tube. The most common problem that occurs during tube exchange is inadvertent removal of the airway exchange catheter and consequent loss of the airway. However, when the entire procedure is performed under direct visualization and the previously made mark on the airway exchange catheter is carefully observed, this complication can usually be prevented. Second, if you encounter any resistance during insertion of the airway exchange catheter, select a catheter with a smaller diameter and lubricate the catheter before insertion. If you encounter resistance during advancement of the oral tube, the tube may be stalled at the arytenoid cartilage. In most cases, you can rotate the tube in a counterclockwise direction and then advance it. If the tube still cannot be advanced, there may be a gap between the endotracheal tube and either the airway exchange catheter or the flexible bronchoscope. If you suspect that this is the problem, remove the tube and replace it with a smaller tube or a flex-tip tube. Finally, if the oxygen saturation is dropping during the procedure, stop the procedure, remove the new tube, and, in case of a nasal tube exchange, replace the original nasal tube over the airway exchange catheter, or, in case of an oral tube exchange, replace it with a smaller tube. If the steps described in the video are followed, severe complications, such as damage to the arytenoid cartilage by the tube, or perforation of the trachea or a bronchus by the airway exchange catheter, are unlikely to occur. Video-assisted endotracheal tube exchange with the use of an airway exchange catheter is an important airway management technique used in patients with a difficult airway. Serious complications can be avoided if the procedure carefully follows a stepwise protocol.